Madam Speaker, Mr. Vice Speaker, Council members, members of the Board of Chancellors, ACR staff, and guests. Good afternoon. For this afternoon's address, I have chosen to revisit two topics placed before us by previous presidents, Drs. Murray Janauer and Ron Evans, as I believe their messages were important then and even more so now. Radiology is changing. Radiologists and all physicians are being affected by a multitude of external forces mandating changes in how we practice, how we are paid, and what our workday is like. Our expectations, as well as those of our groups, our hospitals, and our patients, are all being impacted. I believe we can succeed in controlling our future if we re-examine what Dr. Janauer advised regarding communicating who we are and what we provide to our patients, our colleagues, our regulators, and our payers. I also believe our efforts at communication will be facilitated by refocusing on Dr. Evans' suggestions regarding organizational collaboration. John Quincy Adams once said, "If your actions inspire others to dream more, learn more, do more, and become more, you are a leader." I hope in a small way to provide some inspiration today. In Dr. Janauer's 1996 address, he presented a goal of communication with our customers, which he defined as patients, referring physicians, and third-party payers. He urged us to take responsibility for educating all of these customers about radiology by radiologists. He reminded us that if we don't know what our customer does with our product, we may not have the right product at the right time for the right price. He challenged us to talk to 6 patients a day, saying, "I am your radiologist. Here's what I can do to help you and your doctor," with the hope that our patients would understand that radiology is a critical part of their healthcare team and of their individual healthcare. I realize this challenge is easy for me to meet because I'm a radiation oncologist, and I speak to patients every day. I know that for those of you who work in a radiologic subspecialty where direct patient interaction is part of your day, it's also easy. However, for what I suspect is the vast majority of our members, face-to-face interaction with patients or referring physicians would on the surface be seen as an obtrusive interference in the day's workflow. As it is stated in the article, and even keel in the February 2014 JACR, there are arguably more stressors confronting radiologists today than at any point in the specialty's history. The tension between quality patient care and the demands of ever faster turnaround times and other factors present great challenges. I am old enough to remember when the radiology reading room was an important meeting place for physicians, when radiologists played prominent roles on hospital medical staff committees and provided leadership as well in their county and state medical societies and in the AMA. Perceived time pressures have eroded this involvement. Dr. Janauer's admonitions are more important than ever in today's world as America moves forward with implementation of the Affordable Care Act. As Dr. Janauer stated, we must be involved at the top levels of the managed care mechanisms through which increasing numbers of Americans will be receiving their health care. Our patients, I don't know what progress any of you have had in discussing the role of radiology services in these models, including accountable care organizations, ACOs. In my recent 2-year stint as president of the Maryland Radiological Society, I tried to stimulate interest in discussing these issues with leaders within the Maryland State Medical Society, as well as within the Maryland Department of Health and Mental Hygiene. The response I received is specialists will continue to receive fee-for-service payments. This may work for the present, but with the expectations of cost reductions, with the savings to be used to provide coverage for the previously uninsured and underinsured, as well as the additional promises made in Maryland to CMS to ensure our state's unique all-payer system and reduce inpatient and outpatient costs by hundreds of millions of dollars over the next 5 years, clearly physicians, including radiologists, will be ultimately expected to share the pain. Someone once said, if you're not at the table, you'll be on the menu. This is why I believe Dr. Janauer's urging is so important. If we allow work and personal responsibilities to overwhelm us, and we do not take the time to forge relationships with our patients and our colleagues, we will be out of sight and out of mind when these discussions take place, and they surely will. Do we want radiology to be viewed only as a commodity, to be priced by others whose primary agenda may be to mitigate their own ox being gored, or as a medical service, equal to the work product of our colleagues, be they cognitive or procedural? We must be recognized as physicians providing physician-level services. Communication and visibility are key ingredients to our future success. It is who we know, in addition to what we know, which will make the difference. We must make the effort and make ourselves available. We must actively engage our patients and our colleagues. As Dr. Andrew Rivard, Director of Cardiac Imaging at the University of Mississippi, states in the February 2014 JACR, each time I talk to the parents of a pediatric patient, I have a meaningful opportunity to be the face of radiology. Equally important to Dr. Janauer's urging active communication efforts by individual radiologists are the communication efforts by our national radiologic organizations. My service as an AMA delegate for the ACR has allowed one of their taglines to become embedded in my brain. Together, we are stronger. This is true for all of medicine. It is certainly true for our House of Radiology. National communication efforts would be significantly facilitated by effective organizational coordination and collaboration. In 1999, Dr. Ron Evans shared with us a vision of collaboration in which he suggested developing a single strategic plan, coordinating operations and funding. He suggested, if we do not work together, the specialty of radiology will have a smaller role in medical practice in the future to the detriment of patient care. He pointed out that though one could argue that the more diversity in a specialty, the better, when a specialty cannot focus the appropriate amount of energy and resources on its major challenges, it runs the risks of not meeting these challenges. Dr. Evans' topic of collaboration was also addressed by back-to-back inter-society summer conferences in 2010 and 2011. I call this the $60 million question. Are radiologists, radiation oncologists, nuclear medicine physicians, interventional radiologists, and medical physicists truly receiving an adequate return on investment on their dues dollars? After the 2010 Inter-Society Summer Conference, a task force was created which surveyed our 50-plus radiology organizations. Radiology has more than twice as many organizations as any other medical specialty. As reported in the JACR August 2011 issue, 41 organizations, 82% of ISC members, completed it. These 41 organizations employed at that time 832 staff members. 36 annual meetings were held and 22 journals published. 15 foundations were in existence. The primary focus of more than 85% of the responding organizations was educational programming, which was delivered at their annual meeting. Research, leadership development, and clinical practice were secondary objectives. Collectively, more than 40,000 professionals attend the 36 annual meetings each year. It was, however, uncertain what percentage of the 40,000 were repeat attendees. Total annual expenses for the meetings exceeded at that point in time $30 million, of which approximately $18 million came from registration fees and the remaining from corporate support. For several organizations, overall revenues markedly exceeded the cost of the annual meeting. This operational margin was generated from other educational programs and materials, additional corporate support or accreditation programs. The 15 foundations included a single foundation with more than $50 million, a group of 6 foundations with between $2 million and $8.5 million each, and 8 foundations with $1 million or less in funds. Though 85% of the responding organizations did report more than 300 existing relationships with other organizations, little coordination of activities was identifiable. 50% of the attendees believed there is significant overlap in function among the radiology organizations. 88% believed radiology is poorly served by having so many organizations. The majority of attendees believed our research, educational, political, and philanthropic activities would be improved through organizational collaboration and consolidation. So, if the majority of the participants in the 2010 summer conference believed radiology is poorly served by the status quo, and all of our activities would be improved through organizational collaboration and consolidation, why has there been so little movement in such a direction? Is it organizational inertia, lack of resolve of the physician and staff leaders, or even perhaps organizational or leadership egos? Does each and every program need to have a unique organizational identifier no matter the cost? Whatever the reasons, we, the dues-paying members, are ill-served. We are in an era of retrenchment. Radiology has been a target of successive payment reductions for many years. Not only have incomes shrunk, but many radiology and radiation oncology practices have morphed from a fee-for-service private practice model into an employment model. For individual radiologists and radiation oncologists finishing their residencies, the opportunities for work in the private sector are less. And for some who find employment in a private practice setting, the opportunity for eventual partnership is not offered. As reported recently in the JACR, researchers using Google Trends software to analyze search data identified that the search for radiology residency has decreased since 2004, while the search for radiology salary has increased. The researchers suggested that average salary, health care policy, and the relative unpredictability of the radiology specialty has had a definite impact on interest in pursuing radiology residencies. I suspect most of you understand the potential differences between the mindset of an employee radiologist and a radiologist who sees him or herself as a future partner in the group. We have heard for years about the financial issues confronting our academic colleagues regarding the limits placed on the amount of money available for society membership dues. Though I believe strongly in the value of ACR membership, no surprise to this audience, I imagine, I recognize that unfortunately for some, the mindset between paying for dues with pre- versus post-tax dollars, as well as the various priorities and pressures affecting discretionary spending, may lead some to think twice about continuing their memberships in the various societies they previously supported. The ACR currently represents 74% of all U.S. radiologists. This number should be 100%, especially in light of the socioeconomic and government relations activities of the ACR, which impact on, and when successful, benefit all radiologists. What will happen to the ACR's ability to provide socioeconomic and government relations support to radiology if our membership drops significantly? Support of the ACR for these activities alone should be valued and viewed as mandatory by every radiologist. Perhaps it's time for a different way of thinking. It has been said, if you're not part of the solution, you are part of the problem. When I was first elected many years ago to my state medical society's board of trustees, the then chair of the board invited me to lunch. During our conversation, he charged me with a need to adopt a new perspective. No longer was I to view things as a representative from Baltimore County, my component society, but instead, I should remember that now I represented all of Maryland's physicians. This was a message that resonated, and I took it to heart. As ACR president, I have participated in lots of meetings with leaders of other radiology societies, many of whom I know very well, having served with them on the ACR Board of Chancellors. On more than one occasion, it was said, "Now, when I was in your position, I might have felt or said the same," implying to me that now that they represented a different organization, their view is different. Why should radiology be we-they? Is our specialty so large that it is served well by such partisanship? Isn't this similar to what's happening here in DC, in Congress? Is our country being well served? I suggest it isn't, and neither is the field of radiology. We as leaders want to believe we have our members' interests at heart. But do we really ask them what they think or what they want frequently or at all? Yes, I know that at least here in the ACR we have an active council process. After all, I am a former council speaker. Our council receives input from all over our country and from many national radiology organizations. Our council, however, only meets once a year. And even with the input from our council steering committee and our well-documented college policies, situations and opportunities arise for which policy does not exist, and we as leaders need to respond, to decide, and to act. Hopefully we do so appropriately, but isn't there a risk, both in the ACR as well in those organizations without organized member input, that our leaders may actually be following their own, perhaps unrecognized agenda and not the agenda of our members? Does radiology gain when this occurs? We would be well served if, in addition to asking what is best for our individual organizations, we also ask what is best for our specialty. How can we address the needs of increased communication if we can't coordinate and collaborate more effectively nationally? We need to have a strong, unified voice as our nation's healthcare system continues to evolve. Though there are examples of failed collaborations and expensive duplications, I prefer to cite examples of positive collaboration and coordination. The ACR collaborates with many societies in the development of practice guidelines. That's the terminology today. It may change Monday. The ACR provides resources for many organizations in the areas of socioeconomics and government relations. The ACR has a permanent seat on the AMA Relative Value Scale Update Committee, the RUC, and sits on the Current Procedural Terminology, CPT, editorial panel. I was very interested to note at the January 2014 RUC meeting that the American Rankin Ray Society and the American Society for Neuroradiology both send advisors to the RUC meeting. It was explained to me by both of these organizations' representatives that they view the ACR staff as their staff for these meetings, and we happily oblige. At the same meeting, I was pleased to see ASTRO and the American College of Radiation Oncology representatives working together. We, however, can and should be doing more. At this ACR Council meeting, we will be asked to approve bylaws changes to allow the Canadian Association of Radiologists to have a voting representative on the ACR Board of Chancellors. The CAR has already created a similar opportunity for the ACR to have representation on their board. In addition, we are in the process of strengthening the input of the RSNA on the ACR board and vice versa. Within the AMA, our radiologic collaboration is strong. The ACR provides staff support, and the participating organizations contribute financial support and volunteer leadership to the AMA Radiology Section Council's activities. Though over the years our numbers may be less, our radiology voice within the AMA is strong and our positions are well articulated. Successful organizations create opportunities and influence change to achieve results. Dr. Matt Hawkins, in his resident fellow section report last year, shared with us, and I quote, "Millennials believe that unity and collaboration between subspecialties, between societies, and between egos is essential to develop the single collective voice that will be imperative for our profession in the next era of healthcare. A formal collaborative relationship has been established between the RSNA Resident and Fellow Committee and the ACR RFS Executive Committee. It is expected that this agreement will expand the knowledge of each group's efforts, minimize duplication, and contribute to each other's programming and service both groups' members more efficiently. As Dr. Hawkins told us, this is a tremendous first step. Clearly, many young radiologists look at the size of the RFS in attendance today, want to be involved and engaged, to be part of something bigger than themselves. So, should not we also be working on expanding the knowledge of each other's efforts, minimizing duplications, contributing to each other's programming, and servicing our members more efficiently? The pool of potential volunteers for organizational activities is the same. Competition for individual members' time is increasing. I prefer to leave specific areas for collaboration to the individual organizations and their current leadership. I am sure many potential opportunities exist. Dr. Evans did suggest several goals for collaborative efforts: reduction of duplicative efforts, reduced numbers of meetings and journals, and reducing the total dues paid by radiologists. In addition, he suggested consideration of assigning accountability for 4 major activities and events to specific societies. He even proposed consideration of a national radiology holding company governed by representatives from societies authorized to consider, through a shared vision, our specialty's strategic needs and proactively agree on actions and sources of funding. We clearly have not made significant progress, either as a result of Dr. Evans' suggestions or as follow-up to the more recent inter-society summer conferences. I again ask why. I strongly suspect the ability to charge higher and higher dues and fees will be strained to an unfortunate breaking point. The younger generation of physicians view organizational membership differently than my generation. They demand a different value proposition. Are we ready to provide more streamlined, efficient, less expensive organizations? Do we prefer to continue with business as usual and watch our current models become irrelevant and our organizations disappear like dinosaurs? I truly hope we do not have to follow the Israelite example of wandering around for 40 years for our current leaders to rotate off and out of leadership. Well, if so, since it's been 15 years since Dr. Evans' address, does that mean we only have 25 more years to go to make it through before real changes can occur? All organizations within radiology, large and small, must participate in this dialogue. Duplicating existing programs consumes important, finite resources, financial, volunteer, and staff. We should be leveraging our activities and programs with each other's organizational strengths. The time for business as usual is past. I do not think we can expect our fellow radiologists to continue to spend $60 million annually without an appropriate return on investment. The time for action is now. I know we have the ability to work on these 2 initiatives, communication and collaboration. For years, our specialty has attracted the best and the brightest. All we need is the commitment by our various organizations and their leaders to begin now a dialogue to identify the low-hanging fruit as a first step along the path of coordination and true collaboration. We can do this. As Winston Churchill once said, if we are together, nothing is impossible. If we are divided, all will fail. I would like to close this afternoon with two thank yous. First, I wish to acknowledge the important contributions made by my wife Beth and our children Jenny and Dan. Without their support and ultimate willingness to excuse my many absences, I would not have been able to contribute my energy and time. The second thank you is to all of you. Never in my wildest dreams 23 years ago, when I attended my first ACR annual meeting as the Carrows counselor, did I ever imagine that I would one day address you all as president of the American College of Radiology. It is indeed an honor and privilege to have had this opportunity. I wish everyone an enjoyable and successful meeting.